Dr. CUGH is the Director for Health Systems Governance and Financing at the WHO in Geneva. Prior to WHO, she was at the World Bank and was the global lead for health, population, and nutrition. And prior to that, she was the Director of Human Development at the African Development Bank. So you can see she is a person with extraordinary experience across a range of international development banks. I think another thing that's really important about Dr. CUGH to know is that she has been tackling big questions for quite a long time. And it's opportune that we are following on the last outstanding panel that we just heard on data analytics, because Dr. CUGH has done a great deal of work in dealing with the big challenge of data quality. She has, in fact, in a nutshell, and I think this is the important thing because it actually exemplifies global health at its best, she has devoted her entire life, if you take a look at her bio, to improving access to health care for the world's least privileged people. So Agnès, bienvenue. Thank you so much for being here, and it's an honor for us to listen to you today. So thank you very much, and the floor is yours.
Thank you very much, Keith, and thank you for the kind words. I mean, I'm really, really very humbled. I don't think I deserve all this praise, but it's always very very heartwarming to be introduced in such a nice way by such a great person who is doing so much to bring together all the knowledge there is at global level and bring the academic world to the service of reaching the poor. So thank you, Keith, and thanks for your friendship, and thanks for everything that you're doing to bring rationality and rigor in the global health debate. Thanks also to American University of Beirut for the invitation. It's a really pleasure for me. I'm always delighted to be in Lebanon, such a beautiful city, beautiful country, fantastic culture, and fantastic food, which I'm enjoying tremendously. I already started yesterday, but I intend to really abuse the food hospitality of your country. So thank you for this. And thank for everybody to be here. And what I'm going to try to address today is sort of some of the questions that we all have about the Sustainable Development Goals, and as part of it, the ambitious objective of universal health coverage. And the story that I'm going to try to give you this morning is a story of science, money, and politics. Universal health coverage, as you know, has been adopted in September 2015 by the UN General Assembly as one of the Sustainable Development Goals. It is part of Sustainable Development Goal 3, which is health and well-being. And it is actually 3.8, which is universal health coverage, which is all people having access to the services they need without financial hardship. And if we look at where we are today in that goal, how do we measure ourselves when it comes to our baseline for achieving universal health coverage, knowing that we are in 2018 and we've committed globally as a community. All countries in the world have committed to reach universal health coverage by 2030. So that leaves us 12 years from today, to actually reach that goal. And I'm going to start from actually the data point, so making the link with the previous session, and going to one of these global databases that was presented just before, which is the WHO Global Health Observatory, and link to that the global database on health expenditure. And if I'm clicking on universal health coverage here on this website that you can access, and you can go there and look at the data and play with them, and I look at the different aspects of this, we say that we follow universal health coverage through five groups of indicators. First, we look at service coverage, which is the definition, at the heart of definition of universal health coverage. Second, we look at financial protection, because remember, the definition is access to health services without financial hardship. But we also look under that as the factors that actually contribute to universal health coverage, which are health system strengthening. And then, of course, linked to that, here are health expenditures. And finally, we have a monitoring of the health equity within that. So these five pillars of the monitoring of UHC. And if we look at where we were in 2000, and here this is the map of the world, as you can easily recognize. And this is where we were in 2000. And of course, the darker the green, the higher the coverage. Right? And then you see that in 2000, the dark green was mostly North America and Europe, Australia and New Zealand, and some of the Central Asia region, and Brazil, and then you had a really white block in the Africa region and some in South Asia. So that's 2000. And since then, you see that the map of the world has significantly greened. So this is based on a series of indicators, mostly maternal and child health and communicable disease. And you see that in 2015, which is the latest data point we have, which we presented in the report last year in December, we find that there's been a significant greening of these map of the world, in the sense that we have been progressing on the objective of universal health coverage, which is very encouraging. There's been a lot of progress in those 15 years. And you can see that not only the whole map is significantly greener, but even some areas that were very light and almost white, like India, and generally South Asia has significantly greened and coverage has increased there. China has joined the upper level of performance in terms of universal health coverage. And Africa has actually also improved. It is still lagging behind, but it is better than what it was in 2000. There is a series of indicators that have improved quite significantly in Africa, including immunization, antenatal care, and assisted birth delivery. In fact, WHO estimated last year that about half of the world has access to health services. So this is really a half empty, half full bottle, right? Is half of the world has access, but that means at least half of the world doesn't have access, which is still remains with billions of people who don't have access. And that's our challenge between now and 2030. What we know when we look at the underlying health system contributors to this improvements, we know that there are some fundamental health system issues that contribute to the coverage. And the most central one is health workers. More health workers contribute to a higher level of essential health service coverage. And you see, each bubble is a country, so the size of the bubble is the size of the country. And you see, the more health professionals, the higher the coverage. But we know also that at some point, the coverage is no longer really dependent on the number of professionals. You can increase the number of professionals without necessarily improving coverage. So you have this kind of capping. But you see very, very clearly that at the beginning of the curve, a very sharp slope in which the more health workers, the more coverage. And that's what we find systematically, that in low-income countries, but also in middle-income countries, the shortage of health workers is one of the biggest problems when it comes to achieving the universal health coverage and the SDGs in general, because the world in general is not training enough health workers. We have a true shortage. There is more money than there are health workers. There is money chasing health workers. We have a lot of supply problems. There are probably no more than 5 countries today in the world that train enough health workers as compared to what the market for healthcare is demanding. So this is really one of the fundamental challenges that as a community we need to address, is how we handle that shortage of health workers, knowing that it contributes to migration of health workers, but it also contributes to large inequalities with low-income countries not having the health workers they need, but also within countries, poor areas, rural areas, peri-urban areas have less access to health workers than richer areas. Having more health workers, however, doesn't give you the whole story. It doesn't necessarily mean more equality and access to health services. When we actually, instead of measuring the overall coverage, but we measure the inequalities measured as the difference in coverage with, in this particular case, maternal and child health intervention between the richest and the poorest quintiles, then you find that you don't have that kind of pattern. Right? You actually don't necessarily have a relationship between the number of health workers and inequalities. And you know, most of you know the answer as to why. It's because of the distribution of these health workers. So you can have a lot of health workers in a particular country, but they might actually be concentrated in the urban centers. It's not they might, actually the data show that they are. And because, again, health workers follow the economic demand, they follow the financial incentives. There are a lot of market incentives for health workers' skills. The labor market of health workers is very good. If you're trained health workers today in the world, you are in a good business. Right? And that is really what is driving these inequalities, because the poor areas, the less desirable areas, the less desirable countries find it difficult to attract health workers. We also know that public spending on health matters. And we have also published as WHO a report last year in December that actually looks at these patterns of public spending over time, which is actually increasing. So that's the good news, is in fact we start seeing the transformation of health system financing, in the sense that more and more, as countries grow economically, they also spend more public money on health as a proportion of total health spending. So this transition is happening, and we know that the more a government spends on health, the better coverage of health services. So that is a macro picture. The more you spend on health, the more you have coverage with health services. So that sort of relationship is quite strong, as you can see from the data. However, what the data show you also is the dispersion, right? It's not a very clear, perfect correlation. Far from that. You will see that at every level of domestic government health expenditure, you have very broad variations. Right? So yes, more public spending generally is associated with better services, better coverage of populations, but this can be done at very different levels of expenditures. At the same level of expenditures, some countries are doing much better than another. And particularly, that dispersion is particularly clear at low-income level. So in fact, the less resources a country has, the more efficiency matters, which is kind of intuitive, right? When you have little money to spend, then it's much more important how you spend it, because you have less space for wastage. It's the same for my household. If I have little money to spend on the food I'm buying, then it's very important what kind of food I'm buying, right? Because I cannot throw it away. Looking at the next dimension of universal health coverage, which is the financial protection, which is the fact that healthcare should not only benefit to the person in terms of their health status, but should also not lead to impoverishment, should not lead to a level of expenditure that is actually going to threaten the welfare of the household. So what we see again is kind of some good news in the sense that we know that, again, at the macro level, the more a government spends on health, the less people have to pay out of pocket. So clearly, you have that kind of relationship. And if we look at the picture from 2000 to 2015, we see that some countries can really move on that line. So you see that big bubble, that big yellow bubble, just move lower and to the right, which means this is actually, as you can see, because it's the bigger bubble, this is China. You see that China over time has massively increased, dramatically increased its public spending, and this has led to less out-of-pocket spending as a proportion. However, again, this is a general trend, but it doesn't say that every time a government spends more, that it's actually more protective. We actually have ample evidence from different countries where governments start spending more on public services to provide more coverage, and yet there is no impact on financial protection. Why is it? It is actually because the market develops. As the country gets richer, there is more money for health. People want to spend more money for health. Providers want to spend more. The technology, there is more appetite for technology, more appetite for high care cost. And then you see that, in fact, both private and public funding both increase. So you can have at the same time, in the same country, an increase in public spending and an increase in financial hardship. So people spend on health, government spends on health, but the way government spends on health matters. So, and you can see that because here you will see the bubbles, they have different colors depending on the income of the country. So the blue bubbles are high-income countries, OECD countries. The red bubbles, the green bubbles are lower middle-income countries, and the red ones at the end are low-income countries. And what you see is, if you look at catastrophic spending, which is on the vertical axis, that at every level of income, you have some countries in which there is financial hardship. Right? There is actually a very new study that just came out from the United States, which is fascinating, which shows and it's based on 12,000 cases of cancer over 10 years. And they found that among those 12,000 cases, 40% of those cases lost all their assets. They had to sell everything they had to face the cancer case. So even at a very high income level, even with a very high level of public spending, the United States has a very high level of public spending on health through Medicare and Medicaid and different subsidies to health programs. Even when we have a very high level of public spending, the way it is organized, the way your health insurance is organized matters, and you can have financial protection problem in high-income countries as well as in middle income, as well as in low-income countries. So financial protection issues are not limited to poor countries. They are universal. So that's what we know from the data, and I'm really encouraging you to visit those portals and play with the data yourself and see the countries that are of interest to you. Where do they stand, and how those different data points relate to each other. But let me now move to sort of the more squarely into the money story and the kind of estimates. It's another study that we did, which is much more based on prospective. So what I showed you before is what happened the past 15 years. Now, what could happen? What could happen if we would be able to leverage policies that would get us to universal health coverage by 2030? What we know is if we would invest in health systems is what we do. Right? This is where we invest. This is where we buy inputs. We could prevent close to 97 million premature deaths by 2030. So we actually have the science that says that we could do this. And when we look at how much it would cost about 3.9 trillion over the next 15 years, mostly through investments in low-income countries, about $76 per capita, but also in lower middle income and in upper middle income countries. There is a need to invest in health services to move from half the people having access to 80, 90, ideally 100% of people having access. And we know that if we look at the structure of the cost of what we would need to invest in, that the biggest investment is, again, the health workforce, close to 40%, 36%. The other biggest investment, interestingly, is infrastructure. And when we talk about infrastructure, we're not talking about brick and mortars. I'm not talking about walls. We're talking about, going back to the previous session, we're talking about IT. And if we talk about IT, we're also talking about electricity. And we're talking for low-income countries and some middle-income countries also access to water. We still have, in some countries, 80% of clinics that have no water, no electricity, let alone connectivity. So there is actually a major need to invest in infrastructure. And of course, investing in supply chains, investing in medicine, and general health system strengthening. And this is really the investments that we're talking about. So the question is, if we look at money, and as this 3.9 trillion over the period, most of it actually, most of what we need to invest is primary health care. So you have the sort of general cross-sectoral policy and population-wide intervention, about 10% of the cost. You have the type of outreach services like mobile clinics, campaigns, door-to-door, which would be about 5% of the cost to reach really the last mile. And then the bulk of the cost is the sort of first-level clinical. Right? That primary healthcare team or GP or nurse practitioner that handles generally all the health problems that arise in a community, and that's about 60% of the cost. So altogether, as you can see, is about a little bit more than 70% of the cost of achieving universal health coverage and generally the health SDGs is primary health care. And that, just the primary health care, I was talking about this 97 million deaths. Just the primary health care could actually lead to avoiding 50 million deaths between 2019 and 2030 in 67 low and middle income countries. And you would see that these deaths would mostly be in under 5 mortality, sort of the last mile on child mortality, but also on NCD in mental health here. NCD and mental health is in the purple there. And one key area in low middle income countries is actually tuberculosis. It's like still a major cause of death in low and middle income countries. So can we pay for it? That's the money story. We know that when we do reasonable projection of economic growth, how the GDPs are going to evolve, what will be the level of taxations that will be associated with that increase in GDP, what can we do as reasonable assumption of how much governments will allocate to health? And you know, these are projections, and economic projections are notoriously difficult in a long run. Typically, the IMF doesn't do economic projection beyond 1 or 2 years. Right? Here, we're making a big, crazy projection, which is projecting over 13 years. Right? So I'm just putting all the caveats here. It's like in 2 years, it might actually be completely different. But right now, the fact is the world is quite in a good trajectory. Why? It's because China is growing and the whole of East Asia is growing. India is growing. India is growing at a very, very rapid pace, like 7% last time I checked. And the whole of South Asia is growing. Right? And Africa is not actually growing very fast, but it's still growing. So we currently are in a situation that is actually quite good as in general. And we know that over the past 15 years, expenditures on health have been growing faster than the global economy. In 2015, the health sector represents 10% of global GDP. Right? So that's about 7.3 trillion, and we know that it is going likely to grow. So the health sector is going to represent more and more of the GDP. We know that the domestic public finance has been increasing in those countries. And as I mentioned, in fact, the domestic funding, that's not external aid. Huh? That's the money that comes from government budget and from people's budgets. This has increased sixfold between 2000 and 2015. So from about 300 billion per year to 1,600 billion per year. Except, and this is where there is a message there that is also that we need to take home, except in low-income countries. In fact, in low-income countries, domestic public funding on health has decreased in 30 countries. And it has been at a time where aid has been increasing. So we know that the share of spending from external resources has increased from 20 to 30%, while in the meantime, the domestic public spending on health reduced. So we have a substitution effect. We have a crowding out effect, which we really need to think about and address in the way that we think we are helping these poor countries by bringing more money. But the way we bring money has an unintended effect to actually have governments withdraw their own money. Because they say, oh, the donors are paying for this. So then I can use my money for something else. And that's very, very typical. If I'm in a low-income country, a Ministry of Finance, which when I was at the World Bank and the African Development Bank, I would talk to all the time. They say, well, you know, I have all this global fund money here in that account, and I need to spend it. And in the meantime, I have needs for agriculture, I have needs for water, so I put my own domestic money there while I'm using the external funding for the health sector. And also their absorption capacity, because some of this money sometimes is not easy to absorb. So that actually contributes to that effect. So in fact, what we see is there will be an increasingly limited role of development assistance for health, because already in 2015, while the global health expenditure is 7.3 trillion, while public expenditure of that is a little bit more than half, it's 4.4 trillion, we see that the external financing, the aid monies, is that tiny dot here, right? That little, don't want to do something bad, yeah. So that little thing here, 20 billion, right? You can't even, yeah. So we need to think about how, with this 20 billion, we actually influence that whole envelope. And that's in 2015. We are in 2018. We already know that that little dot is stable. It has not increased. We know that this big envelope has grown, right? And it will continue to grow. So that we are at the beginning of that effect, right? But in 10 years, in fact, that effect is likely to be exaggerated, right? So when you look next to it here, you see that already in upper middle income countries like China or Brazil or South Africa, aid represents less than 1% of total health expenditure. If we go in lower middle income countries, then countries like Vietnam, then it's still only 3%. And it's only in the low-income countries, which now are between 30 and 35, that we find that aid really represents a significant contribution in terms of the actual share of public spending, which is, of health spending, sorry, which is about 30%. So this is really an increasingly changing world in which we need to rethink the way international money is actually going to contribute to this agenda, because most of the resources will be in the countries. And a large part of that will be private. The question is how you transform the money that is out of pocket, how you transform the market forces in a collective action. Because 85% of the cost, you remember first I showed you the cost, the 3.9 billion. So when we compare how much it will cost to how much money will be there, we see that 85% of delivering on the universal health coverage can be met with domestic resources in low and middle income countries. So it's only 15% that will have to come from external resources to achieve this. So that brings me to the sort of conclusion of this talk, which is if we have the science, and we know we can achieve this, because we have the evidence from science that we can reach universal health coverage, some countries have done it, that we can reduce mortality, we can get to very, very low levels of child and maternal mortality, very low levels of mortality linked to communicable diseases. We can also curb the epidemic of non-communicable disease through prevention. So we have the science. We know pretty much what to do. We also have the money. So if it is technically possible, if it is financially possible, what are we left with? Well, we're left with politics, because it's all about that transformation. It's all about how to make the money that will be there to fund what is actually going to make a difference. And we know that in healthcare, it's possible there are some interventions that are really best buys. When we think about vaccination, when we think about tobacco cessation, we think about breastfeeding, there are interventions that cost very little, and they buy a lot of results in terms of health. So the question will be the politics. And this is really increasingly what we are working on as WHO and with countries, is how to make politics work for health. And I'm just starting with aid as just sort of a first illustration point of the politics. This comes from the World Development Report 2004, which I was lucky to be part of, which is, this report was about how making services work for poor people. And it really addressed the political economy of services. And what this report says is there are three main groups of actors in politics, right? The main actors are people. There are people. That's who we are. We are human societies. And among these people, you have poor people. So there is first the question of the power relationship between the poor and the rich, or the poor, and in the middle class, and how the middle class allies with the rich or the poor. And then you have the decision makers for collective actions, which are the politicians and the policy makers. And finally, we have the providers, which are the market, right, on the right here. And this is the politics at country level. This is on the right. When we bring global health into that, when we bring external forces, then we bring another triangle. That comes here on the left. And in that triangle, you have another interest group. You have another group of taxpayers. You have the taxpayers of donor agencies that intervene. You have the aid agency. So the question will be really how you align all of that, and particularly how you align the interest of people in poor countries with the interest of people in rich countries, so that they actually go for the same thing. And it's not really necessarily easy. Already in a country, it's not easy to find a social consensus. Now finding a global consensus with more than 7 billion, 8 billion people on the planet agreeing on what we need to do is not easy. That's the sort of big question of our time, or how we go about this. So I will really finish by saying that what we're going to go through over the next few years, we're already there, is the health sector playing a growing role in the economy. Because among all sectors, this is a sector that is growing. In fact, industry, when it comes to employment, has become so productive with robotization, right, with automation, that is going to create less and less jobs. But the health sector is going to create more and more jobs. Right? And there will be more and more demand for the health sector. So we see that's the work of the Commission on Health, Employment and Economic Growth that was put together in 2016 from WHO, OECD, and ILO, which concluded that the health sector is increasingly becoming an economic sector, and it contributes to economic growth, and it contributes to jobs, and it is a key sector in the fourth industrial revolution, because it's a data intensive, because it is labor intensive. So we increasingly will have to manage these market forces with innovation, with new products coming all the time. In France, they found through both a combination of retrospective and prospective analysis that everything we know in healthcare, that half of what we know in healthcare changes every 4 years. So we will have to adjust to that. So there will be money, there will be a lot of technology, there will be economic interest, and we will have to manage that, knowing that through the value added of the health economy, there will be contribution to growth. So there will be pressure for expanding this economy for jobs reasons, for economic growth reasons. There will be market pressure. There will be citizens' pressure. And it's not the bad thing. It's not a bad thing if the public money is invested wisely in actually getting societal returns from that, right? If it's not just captured for the interest of the private sector. So what do we do? Clearly, more money will come to health. The question is how and for what. Will it be uncontrolled private expenditure, funding a lot of technology that we don't really know what it is doing, and creating a lot of benefits and businesses? We already hear that in equity funds, the health sector is off the chart in terms of returns on investment. Or is it going to be a societal sector which actually producing public goods, common goods? And so reaching UHC will require responding to this question. And at the end, you remember the triangle. The key is people. People are the agencies. They are consumers. So they can affect the market by using or not using certain type of services. Health is produced by people. Health services are just the repair shop. So how they produce their whole health, how they use services, how they give market signals, and how they act as citizens for collective action. That's where politics is, and this is where we all need to act. Thank you very much.